Hi friends, this is again a very interesting case where the glaucoma drainage device has already been implanted superiotemporal. Patient is going to get operated on the right eye. Patient is having glaucoma, CD ratio 0.7. The bleb is almost extending to the nasal side. So you can't operate on superiotemporal, you can't operate on temporal side. So the only place which is left is the nasal, or superionasal, better to say. So Phaco in such cases is very easy. But as far as manual SICS is concerned, it's very difficult because you can't go for clear corneal incision, as this is going to create a lot of astigmatism. Patient's vision is already 6/60. So we want to preserve the vision as well. Now, after identifying where the conjunctiva and Tenon's capsule, they are separate, from there we'll start doing paratomy. After doing the cauterization, we'll start making the tunnel. Now the next important thing is that since the tube is there in the anterior chamber, it is very flexible. If you are going to do the sandwich technique in such cases, the nucleus is going to rub against the tube, and this may lead to extrusion, or this can lead to the blockage of the tube and hence the failure of the device. So how we are going to take care? And the most important thing is that while irrigating and aspirating the cortical matter, sometimes they get into the pipe and they can block the tube. So how we are going to operate in such cases, let's see. Now this is how the tunnel construction is being done. After entering into the anterior chamber with 2.8 keratome, stain the capsule and do the capsular rhexis. So far so good. After doing hydrodissection, we have to take care so that the nucleus comes in contact with the tube as less as possible. So we are going to avoid the nucleus touch while delivering the nucleus into the anterior chamber. Once the nucleus comes into the anterior chamber, so I prefer to go for tunnel fracture, so that 1/3 of the nucleus is broken down and the shape of the nucleus becomes like D-shaped. So this D shape, then it is rotated. Since the space is very less, when you divide the nucleus, there is ample of space so that there is no touch to the tube. Then you can either go for Phaco sandwich, or you can deliver it by using a wire vectis. In this case, retrobulbar anesthesia was given to keep the pressure on the lower side. Now, when you clean the cortical matter, we want that they should not seep into the tube. So that's how, if the pressure is low, these particles, they cannot travel from lower pressure gradient to the higher pressure gradient. So this is how we are going to avoid the smaller particles to get stuck into the tube. Now this is how the fracture at the tunnel is done. You'll appreciate the D-shaped nucleus. Now you rotate the flatter part, the D part, nasally. Now there is ample of space. This is not going to touch the tube at all. Now the choice is yours. You can go for Phaco sandwich, technique, or you can remove it by using a wire vectors alone. After this, there is a very important step, that is irrigation aspiration. So we have to avoid so that these smaller particles, they don't go inside the tube and block it. So what I have done is, I have instructed my assistant to put bud over the tube. So this will prevent the smaller particles to block the tube. Once the cortical matter is cleaned up, now we implant an IOL. Almost in all my cases, after implanting the IOL, I use keratoscope to see the mires. They are regular and circular. After this, we have to take care of the conjunctiva. The conjunctiva has to be opposed, perfectly aligned. There should not be any leakage, because this can lead to overflow, bleb may be flattened, and the purpose of the device will be failed. Now I will apply 2 stitches on either side and check if there is any leakage. So the mire seems to be quite circular. I'm very much satisfied, and we'll see how much of the astigmatism is there post-op. So pre-operatively, patient had 6/60 vision, CD ratio was 0.7, IOP was 10 millimeters of mercury. So hopefully the vision should remain slightly better, as the CD ratio is about 0.75, and I'll show you the visual recording also. This is the first post-op. Cornea is absolutely clear. Vision recording was done and patient could read about 6/12 partial. Patient was quite happy. Now he comes back after 10 days. Sutures were removed. IOP was 10 millimeters of mercury. Cornea was absolutely clear. Tube was very much in place. And vision recording was done, which was about 6/9 unaided. Cylindrical axis was plus 0.75 at 180 degrees. Since this was only a second case, so I wanted to share my experience with drainage devices. I hope you like it and it can be of some benefit. Thank you.